Hello, everyone. My name is Snehal Desai, and I'm going to go over depression and its symptoms, and as well as some antidepressant treatment mechanisms, as I will describe in most of this presentation here for your reference. Um, and I'll try to keep it as short as possible with the important information for your benefit. Um, as you can see in this next section here, Um, these are some of the topics you might see on the NAPLEX, especially things that might overlap one disease state to another. Like you might see some of the same medications used for anxiety and uh, as used in um, the same way as used in depression. You might see some antidepressants used in other disease states as well. Maybe not as much. Maybe bipolar disease, you might see some as well, and any mania symptoms. Just kind of understand that right now it's just mainly focused on depression. We're not going to really look too much into other disease states right now, but I'm going to at least um, review some important points in this presentation, so you guys should take note of that. Um, So, does anyone if anyone has any questions, please feel free to let me know. You can type it here in the chat. Um, so, as I said, my name is Snil Desai, and if you have any other questions, just feel free to let me know. This presentation is mainly going to cover depression, symptoms, maybe certain side effects, and I'm going to review some of the concepts you should know as in terms of like mechanism of action of many of these medications. Um, so I see a few of you have already started joining, but if you have any questions, feel free to type it here in the chat, um, and we will look into it more and get back to you on it. Um, Again, my goal is to really prepare you really well for this exam and for your knowledge as well, so that you know to so we can help our patients and treat these diseases, helping them and um, resolving issues and everything. So let's take a look at all of these treatments, at least mechanisms, so that you guys have an idea as to how they're used, and we'll go from there. Um, so as you can see in this uh, slide here, I kind of briefly put together a few of the common topics you might encounter on an exam. Um, Certain things here like depression, anxiety, most of these kind of neurology or psychiatric diseases that you would actually see on an exam are covered in these topics. So, like epilepsy, seizures, Parkinson's disease, Alzheimer's. Um, don't get confused between Parkinson's disease and Alzheimer's. I've seen some pharmacists who sometimes get mixed up with the medication between Parkinson's and Alzheimer's. So, um, when you just think about Parkinson's, like um like you're basically parking where you need to um move out of a parking spot, so it's like dopamine is going to help kind of cause that reward stimulation here, so like using carbidopa, levodopa, those kinds of medications. Just don't get confused between that and Alzheimer's disease. um and um, anxiety medication. Many of you, some of you may have seen prime practice one way or another, common controlled substance that's been dispensed for helping patients with their anxiety. And it's very crucial to know that, because it's a controlled substance, and you as a pharmacist should know, especially if you're going to look on if you look on the NAPLEX course outline, it states something about knowing some think about the ethical portion of it, just understanding that when it comes to controlled substances, you have to know if that prescription is legitimate, is it valid, and is the doctor's license valid, DEA is valid, so that you as a pharmacist can prescribe that patient. Is it for that purpose? Alprazolam, for example, Xanax, and you know, it's kind of important to see some medications like that, that patients take sometime for their anxiety. Um, Schizophrenia meds, we'll talk about more of that in the later presentations. Um, Epilepsy, seizure medications, Stevens-Johnson syndromes. I'm sure you have seen or maybe heard of it one way or another, like those severe rashes. We actually had one in practice where a patient actually had a Stevens-Johnson syndrome reaction. And, they were on some anti-seizure medication. And so it's very important to understand some side effects to it, and correlating some side effects and symptoms with the disease state can be helpful, especially when you see those kind of things in patient cases. Um, and also like depression mechanisms, depression. When it comes to depression, you know that if you're going to get any kind of drug for that patient, you're probably going to start out like you're probably going to see a lot of patients starting out with an SSRI or selective serotonin reuptake inhibitor. So that's usually going to be the first line therapy: citalopram, fluoxetine, sertraline. I have in paroxetine in some cases, but it's also important to know some of the side effects of these kind of medications. So we're going to talk about how these medications work, but we'll also talk about some of the toxicities and maybe some benefits to some of these medications as well when it comes to other problems that patients experiencing aside from depressed mood and loss of interest. So let's take a look here. So when it comes to depression, during the first 2 weeks or 14 days they're on, that they are feeling depressed and there's loss of interest, that's where depression actually starts. So then when you add those 2 weeks of having that time period and 5 symptoms, which are listed down here: sleep changes, interest, loss of interest, guilt, having the guilt, loss of energy, loss of concentration, loss of appetite, some weight changes, psychomotor energy, suicidal ideation. Those are some symptoms that a patient could experience along with depressed mood and loss of interest for 14 days to create what's known depression. So this is per the DSM guidelines. I would recommend you look into more updated information on the diagnosis of depression, but as of this presentation, this is especially important to understand. If you see any of these that patient experiences on the test, like you have a case and the patient is not able to sleep well, they don't have very much interest, um, they feel guilt, they're like really sad, they have low energy, they don't have much energy, they're feeling weak, um, they're not really concentrated. Let's say a patient is really not in the mood of eating anything, so there's no appetite. Um, you know, feel like they want to, and sometimes you might see a patient case feeling like they don't want to, live anymore, kind of thing. So all those things, make up depression, along with having that kind of depressed mood and loss of interest. So you should, if you see this on a test, just notate some of these kind of things. My recommendation here is definitely knowing these um, different symptom states here, and just kind of would kind of memorize or understand these, so that you guys can understand them on the test. Um, if you see a patient case on it, you guys can use it to um, mark off a check off, like these are the symptoms that patient's experiencing. And just keep in mind that some of these symptoms um, also might occur while patients on antidepressant. So, like suicidal thoughts, I know some of you I may have, or some of you may have seen a um, a side effect or of some sort that showed that suicide thoughts is a side effect or black box warning. That's true. So some of those medications might lead to that, but you should also inform the patient that there are ways to control it too. Maybe uh, if patients having that suicide thought, they should definitely call the doctor. Stop that medication, call the doctor, and to change it to something, or decrease the dosing, or decrease the strength, so that the patient is able to um, uh, prevent their uh, prevent them from having those types of thoughts. So um, that's important to know. Appetite. Sometimes patient has low appetite, and there are certain antidepressants that would do things to help increase the appetite. So you might have a test question on this, and it might ask you what is the best medication to help with appetite stimulation. I have seen it in practice. There is one antidepressant that patients might be prescribed for stimulating their appetite. And so it's important to know that, for the test. So kind of connect some of these kind of symptoms with ways to treat them as well with these antidepressants. Now look at the mechanism here. See how like see how the normal one is like it's normal flowing of these neurotransmitters, and then when they get depressed, you see less of the triangles and less of the circles going from one neuron to another. And you can see this one as well when you have the medication, which is like a yellow circle right here in the corner. That would indicate more of like the medications helping stimulate the neurotransmitter release into a synapse to get to the other neuron. So just to understand, that the main functioning of many of these antidepressants is to stimulate that release of neurotransmitters, so that the patient can um, function normally without feeling more depressed. So we're going to be talking about a lot of these neurotransmitters, many of them which are things like the alpha 1, you might see so alpha 2 block, alpha 2 receptor, you might see something on the muscarinic receptor, histamine receptor, serotonin receptor, norepinephrine receptor, so at least and dopamine receptor. A lot of these neurotransmitters are used for treating depression, so you're going to have to understand um, how they all fit when these medications are taking place. So how these medications work in treating depression and stimulating these types of neurotransmitters so that the patient is able to function normally. So these are some of the classes of medications here: selective serotonin reuptake inhibitors, SSRIs. These are things like fluoxetine, sertraline, citalopram, paroxetine. You got serotonin and norepinephrine reuptake inhibitors, SNRIs, atypical antidepressants, TCAs, which is the tricycle antidepressants, and monoamine oxidase inhibitors. Um, so these types of things are rarely used, like tricyclic and monoamine oxidase inhibitors, but they are still there, and sometimes patients use these or are prescribed these medications to help alleviate these depressed symptoms. So it's kind of important to know those as well. Um, when it comes to atypical antidepressants, one medication I want to point out is the bupropion or Wellbutrin. Now, Wellbutrin is also a drug, or bupropion in terms of generic, is used for treating smoking cessation, or for preventing a patient from smoking, or for smoking cessation. They use it as a smoking cessation drug. So it's kind of a benefit both ways there, not just as a antidepressant, but also as a way to, help the patient from basically, help the patient when it comes to like smoking cessation therapy. So that's one good thing there. And like there's a couple of good benefits with some of these drugs, so it's very important to know also some outside parts of it too, and also to notate some of the drug interactions. Now, when it comes to drug interactions, many cases you might see a patient on pain medicine like tramadol or something, or maybe an antibiotic. Some of these medications might interact with antidepressants and cause what is known as serotonin syndrome. Now, I'm not going to talk more into that topic, but it serotonin syndrome is, where it's like basically they're getting too much serotonin in their system, and it's going to cause them to feel like they're going to get more. Um, it's going to make them feel worse. So it's kind of important to annotate some drug interactions here, um, and see how serotonin can contribute to certain side effects as well, and bleeding and things like that. So just notate that. There was a short I had posted a while ago on how um, blood thinner might also contribute to serotonin release or something like that. So you'd have to look at that short again and see what it's about. But there is possibility of increased bleeding risk too, especially with serotonin type of drugs. So I'd recommend that you take a look at that short again on that, um, especially when there are some platelets carry the serotonin, and then um, especially in the gut and those kinds of areas, and then if it can affect various parts of the body this way too. So it's not just going to occur in the brain, but it can affect other parts too. And also, you would see like TCAs, certain tricycle antidepressants might affect like the heart, for example. So it might be a reason why the patients don't use TCAs too much, because um, of the extreme side effects that it might cause. So it's kind of important to know um, these types of things so that you can um, understand, and especially when counseling patients on certain medications that contribute to these types of side effects. So take a look here on this slide. You see that I labeled a lot of these classes of medications here SSRIs, SNRIs, atypical antidepressants, tricyclic antidepressants, MOAs, MOAI, um, and then there's some other medications here. And then you can see here, I can just name a few here, like fluoxetine, like being more long-acting. Paroxetine might have some more anti-muscarinic or anticholinergic side effects. Sertraline might be safer for the heart. Citalopram might lead to more QT prolongation, so kind of watch out for that. Then SNRIs like duloxetine might be useful for patients having diabetic neuropathy. Venlafaxine, you got desvenlafaxine, which is a more active form of venlafaxine, and then levodopa, which I haven't really seen that medication much in practice, so you might not see that on the exam. But it's good to at least have a general idea of that medication as well. Atypical antidepressants, trazodone, mirtazapine. Mirtazapine is a drug that might appetite stimulate or stimulate appetite. So at least having an idea of that. Vortioxetine, phenazidone, bupropion. We talked about smoking cessation as well. Then you have nortriptyline, amitriptyline. These are tricyclic antidepressants. Doxepin, desipramine. So having an idea of those. Then the MOAIs, transilopramines, venlafaxine, isocarboxazid, salicyline, and then there are others like aripiprazole, or in other words, a brand name Abilify, and then Seroquel or quetiapine, and then lithium or Lithobid. So just kind of understand certain side effects or certain things that might help with when it comes to patient cases and things like that. So let's take a look at the mechanisms. So in terms of the SSRI mechanisms, SSRIs are generally first-line therapy for depression. The first thing it's going to do is it's going to block this serotonin reuptake transport. That's essentially what it's going to do. And it's going to prevent that from bringing back the drug back into the presynaptic part of the neuron. So that's essentially what it does here. Not really too much going on here, just blocks that serotonin reuptake transporter, so serotonin can go to the postsynaptic neuron. And then I listed out and already talked to you about a lot of these side effects and things here on the slide, so you guys can take a look at that. The serotonin norepinephrine reuptake inhibitor is similar, but it blocks the norepinephrine transporter in this case, and not just the serotonin reuptake transport. So there's going to be two neurotransmitter emitters in this case. So I kind of split the neuron in half because there's going to be two different neurotransmitters that are being released here. So just wanted to show you here for your reference how SNRIs might help patient more. One other thing I want to note is that norepinephrine is also used as like a vasopressor, so it might kind of increase the patient's blood pressure as well. So kind of keeping in mind that some of the some of the neurotransmitter here can play a role in causing other types of symptoms as well, like the blood pressure and all. So just keep that in mind. If you see a patient case having high blood pressure and they have this depression, first line, I would just recommend go with the SSRIs. Do not go with any SNRIs unless their blood pressure is like at a very normal level. So just want to notate that for you. And we talked about all of these too. Okay, this might be a little messy diagram. The atypical antidepressants. Um, One example is bupropion. Um, it's going to, in fact, let me just erase bupropion for a minute here at the top so you guys can, it's for all the depressants here, atypical antidepressants. You can see here like trazodone is in the gray. It's kind of blocking certain transporters here and certain types of receptors. Um, so let's start from the trazodone, the gray lines here. First one is it's going to definitely go ahead and block that serotonin reuptake transporter. It's also going to block the alpha 1 receptor here, and then it's going to block the um, one of the other, serotonin receptor as well. It might also block the histamine receptor. So it has some role there, has a lot of role in blocking many of the receptors here. And then when it comes to another medication, bupropion, it's going to mainly block the dopamine transporter as well as the norepinephrine transporter. Mirtazapine is going to block the alpha 2 receptor and also serotonin, and that's pretty much it looks like here. The vilazodone is going to block the one of the serotonin transporters, serotonin receptor, or actually going to be used as an agonist there, and in the presynaptic parts as well. And it looks to me it's going to also block the serotonin reuptake transport. Then vortioxetine is going to be also playing a role as an agonist or partial agonist for serotonin receptor as well, and but blocking the serotonin reuptake transporter. I think those are the main ones here. And if you have any questions, feel free to let me know. I already kind of drew out the table here so you guys can see it for your reference. I know that the diagram might be confusing to you, so you can see how all of the parts get blocked. Everything in red is where these drugs block those areas. And in the TCA. The TCA is interesting. It's going to block 4 types of receptors here. It's going to block the muscarinic receptor. It's going to block the histamine receptor. It's going to block the alpha 1 receptor. And it's going to block the sodium channels as well. So I kind of drew it in a heart form because the sodium channel actually is used mainly for the heart. So that's that. And then it's also going to block the norepinephrine transporter and the serotonin reuptake transporter as well. So you could see here that the TCA might have a little bit more concerning types of side effects, especially when you're going to deal with the heart. And, that's going to be a concerning factor. Wouldn't really consider this as a first line therapy for a patient because of the fact that you're already now going to go ahead and mess with the heart, especially. And alpha 1, some of you probably already know that alpha 1 is typically used to help patient, when they have, for example, a patient having anaphylaxis, you already know alpha 1 is actually one of those types of agonists that's used to help, uh, you know, prevent anaphylaxis symptoms and stuff like epinephrine. So kind of used as a vasoconstrictor. Well, now you're going to use TCA to block the alpha 1, so now they're going to increase more vasodilation instead of vasoconstriction, so their blood pressure might get a little bit lower this way. And so it's kind of important to know this. Other sites, the muscarinic receptor might have a little bit of anticholinergic effects as well. So kind of just understanding about that as well. So, and then you have MAOI, which are the monoamine oxidase. This one's very interesting because what the MAOI does is it's just a way to control the amount um, of the neurotransmitter particles within the neuron so that it's not overloaded, and it keeps it from basically having too much. So that's why it's used as like a regulator to break down some of the neurotransmitter and get rid of those so that it can you know prevent certain side effects and things. So um, that's especially what this monoamine oxidase uh, does. Now, when you inhibit the monoamine oxidase, then you're going to increase more the neurotransmitters, and then it will be more released into the other nerves in the body. So it's going to um, increase the amount of neurotransmitter in that nerve system. So just kind of know that. Uh, just wanted to show you here how the MAOI works. I think that was pretty interesting to know how it can prevent the breakdown of serotonin, dopamine, norepinephrine transmitters. Um, so that's pretty much it here. I do want to mention here, if you're going to prevent the breakdown of monoamine oxidase, then you're also going to increase the chances of serotonin syndrome as well, because a lot more serotonin is going to be in the system as well. So I hope that kind of makes sense to you all, um, so that you can see why or how serotonin syndrome might be caused. It's due to the increased levels of these neurotransmitters, and that are caused by these some of these types of medications. Aripiprazole and quetiapine are, these are the other types of medications patients might be on. Aripiprazole particularly blocks and also used as an agonist for like serotonin um, or 5-HT2A as an inhibitor, and then it's used as an agonist for 5-HT1A, and then dopamine as well, so the D2 receptor as well. Whereas quetiapine just blocks the D2, blocks the alpha 1, blocks the histamine receptors. And that's pretty much what it does. And I did list out some notes here so you guys can see it here. When it comes to quetiapine, if it's taken as a low dose, then it's going to be the histamine. H1's going to dominate. And when it's taken as a moderate dose, it's going to lead to more antidepressant side effects. And then high dose going to lead to more antipsychotic effects. So that's those are kind of little differences here, low to high when it comes to dosing of the quetiapine. Then this is another interesting mechanism I thought you guys might want to know is the lithium. Lithium blocks two parts here. It's going to block the inositol monophosphate, and and also it's going to block the glycogen synthase kinase 3. Now the glycogen synthase kinase 3 is useful when it comes to, like, it's used as an enzyme in terms of like programming the neuron or like the DNA structure or something, neuronal signaling in there. So this is important because if it blocks it, it's going to um, allow for more neuronal survival. So it's going to kind of change the programming structure. to make sure that the neuron can stay longer. And then the inositol monophosphate is going to prevent overactive neuronal signaling if it blocks that. And that's pretty much it for the presentation on some of these mechanisms. It wasn't a very in-depth, comprehensive overview, but I hope this kind of gives you an idea of some of the um, treatment mechanisms that you can see here in these diagrams, especially before you take the exam, so you can um, practice with these. So hopefully that helps. And if you have any questions, please feel free to let me know. Um, and I'll see you soon again. And thank you for watching. And I hope you all have a good day. Thanks.